Hello and welcome to this e-session. I am Dr. Rajeshwari B, Senior Lecturer in Pediatrics. In this module, we'll explore mouth breathing, a common yet clinically significant condition in children. Our presentation is divided into 6 key sections: the definition, classification, etiology, clinical features, diagnosis, and management. Let's begin with the definition. Mouth breathing is defined as an habitual respiration through the mouth instead of the nose, as described by Sassoni in 1971. It is also referred to as oronasal breathing, especially when both nasal and oral routes are used. It is more than just an habit. Mouth breathing can reflect deeper anatomical or physiological problems that may affect a child's growth and development. Next is the classification given by Sim and Finn in 1987. According to him, the mouth breathing is classified into obstructive type, where nasal airflow is blocked due to causes like enlarged tonsils, nasal polyps, or deviated septum. Next is the habitual type, where the child continues to mouth breathe even after the obstruction is removed. Next is the anatomical type, which occurs due to a short upper lip resulting in lip incompetence. When we see into the etiology, the common causes of mouth breathing include developmental and morphological abnormalities such as underdeveloped nasal cavities or short upper lips. Next is partial obstructions like a deviated nasal septum or nasal tumors. A genetic predisposition, particularly in ectomorphic children with narrow tapering facial structures. The medical causes include enlarged adenoids or tonsils, nasal polyps, allergic stomatitis, and atrophic rhinitis. When we look into the clinical features, first, the general signs include dry oropharynx and possibly low-grade esophagitis, narrowing of the maxillary sinus and nasal cavity, a straightened oronasal pathway with swollen turbinates. In severe cases, it may also lead to sleep apnea syndrome due to lingual tonsil enlargement causing airway blockage during sleep. Now, coming to the clinical featured appearance as described by C.V. Tomes, the children may develop a distinct facial features such as a receded chin, short upper lip, and the nose may tip upwards. Uh, the child will have features like adenoid faces, wide held lips, long narrow face, and a flat nasal bridge. When we look into the dental and skeletal features, the dental signs include rolled gingival margins, enlarged papillae, and a low tongue posture. Narrow maxilla arch, high palatal vault, incisors protrusion, and anterior open bite may be seen. The mandible may appear retruded, giving an imbalanced facial profile. There may also be an increased risk of dental caries, plaque accumulation, and chronic gingivitis. Now, how to diagnose mouth breathing? The diagnosis starts with the clinical observation. For this child, the lips will stay apart, no movement in the external nares during inhalation. They will have a forward head posture and a dorsal nasal hump may be seen. Functional test includes the micropore tape seal test, sealing the lips and observing the discomfort, mirror or fog test, noting the condensation during the exhalation, water holding test, whether the child can hold the water in the mouth for 3 minutes, the butterfly test, where the fibers move during the oronasal breathing. Whether if the fibers flutter downwards, they are the nasal breather. If the fibers flutter upwards, they are mouth breathers. Coming to the advanced diagnosis method, rhinometry, where it helps to measure the nasal airway patency. This can be used in children. Then the cephalometric analysis, which assess the airway space and skeletal pattern. These tools give us the quantitative data to confirm clinical suspicion. Coming to the management includes lip exercises, which should be done 15 to 13 minutes a day for 4 to 5 months. Then the use of oral and vestibular screens. habit correcting appliances, and most importantly, deep breathing exercises. Very coming to the lip exercises, a very simple daily exercises practiced for 15 to 30 minutes over 4 to 5 months can significantly help retrain oral muscles. Some of the lip exercises mentioned here are the button pull exercise, stretching of the upper lip using a popsicle, tug of war exercise where a thread is tied to a button and compressed between the lips, and it's like pulled out so that the lips can contract. Next is the holding and pumping of water, like we do in gargling, but we have to use a closed mouth and hold and pump water. Next is popsicle harmonia or using any wind instrument. Coming to the oral screen, it was first given by Newell 1912. It works on the principle of force elimination and application on the circumoral musculature, but it is contraindicated in patients with nasorespiratory distress or nasal obstruction. It is indicated in cases of lip incompetence and labial flaring of maxillary anterior teeth. Some of the modifications given by various authors includes addition of breathing holes, anterior loops, or even pacifier attachments for younger children. The newer techniques use a myobrace appliance for this habit correction, where it is a modern habit correcting device. It helps to retrain the tongue posture, swallowing, and nasal breathing. There are specific models for every age group, like it is divided into junior, kids, teens, and adults according to the specific age. The different sizes, like in small, medium, and large sizes, are available so that they can insert, and it is basically a thermoplastic material which can be inserted in the mouth and should be worn actively for 1 hour and during sleep. This will reduce the habit progressively. Then the other features in this myobrace appliance include the breathing holes and the use and the addition of lip bumper into it. In conclusion, mouth breathing is not just a habit but a multifaceted condition with consequences on facial growth, dental health, and overall well being. Early identification and timely intervention can prevent long term complications and improve the child's quality of life. Thank you for joining this session. Remember, early recognition and management of mouth breathing is vital for promoting healthy development in children. Thank you.